Okay, good morning, everyone, and welcome to the Brain Technical Imaging Q&A session. I'm Megan O'Reilly from Sunnybrook Research Institute in Toronto, and one of the moderators.
Good morning, everyone. I'm the co-moderator, and my name is Viola Rieke from the University of Utah.
So we have four of our authors here this morning, or three of our authors here this morning. And so we're just going to start off some questions. So Steve, I have a question for you from the chat. So very nice presentation to start with, and an interesting approach. So apart from aberration correction, CT imaging is also needed to identify intracranial calcifications to segment as no pass zones during thermal FUS treatments. And so are your MR simulated CT images able to pick these up?
Not sure, actually. We were doing these experiments on ex vivo skulls, and there weren't any that I were able to see, but we'd have to do the experiments in vivo just to confirm.
Okay. And I guess a question I had, so right now your sequence I saw takes about 36 minutes to acquire. So how fast can that be ultimately implemented if you optimize your sequence? And what's it going to take to get this into the workflow of one of these clinical treatments?
So right now, the registration for the preoperative CT to the intraoperative MR takes around 10-15 minutes. And so getting to that time frame would become clinically relevant in terms of getting the scan time down from 36 minutes down to 10 to 15 minutes. I'm not exactly sure. We'd probably have to go offline and talk to my collaborators to confirm that.
And I have a follow-up question to that, because if you want to have that in the workflow with the if you want to avoid the registration and have to take the images with the transducer in place, do you think the image quality from the current system with body coil imaging would ever be sufficient enough to get this kind of image quality to do this, use the MR?
Yeah, having the B1 artifact caused by that head transducer could be a problem. And so any approach to minimize it, such as the propeller beanie, would be really great.
Okay.
Okay, and I guess one more question. So how do you calculate your speed of sound and attenuation from the MR images?
So right now we are just using we're just scaling the MR simulated CT values. So right now they're normalized to a range of 0 to 1, 0 for water, 1 for bone, and we're scaling that to 2,000 Hounsfield units to emulate CT. And these images are then passed to the InsightTech algorithm, which does its own calculations.
Okay, very interesting. So we may circle back to you if we have time, but I'd like to ask Sumit a question. So very nice presentation and nice approach. I'm always interested, the MR-RFI approach for phasing seems like it has a lot of potential, since you can correct the actual focus. So potentially has the ability to surpass image-based correction using CT. But I wondered, so right now you have a fairly rapid approach, and it seems like it works well with your basic simulator, or your basic aberrator, but you have only 4 logical elements in that very simplified aberrator. So how does that scale to a more complex aberrator, and is there a hit on time that it takes to do the correction?
Sure. So Megan and Viola, thanks so much for moderating this session. The question was scaling from a fewer number of logical elements to a more realistic system, which typically has anywhere from a few hundred to a few thousand elements. So I guess the question is, I guess the answer is we don't know entirely. So the system that we use at Vanderbilt has 128 elements, and we feel pretty confident that we would be able to scale that up within a realistic acquisition timeframe. So typically the way that most logical elements are done, at least in the work that I've seen with MRRV, is that they tend to use Hadamard groupings of elements, which is ideal when we're doing these sorts of refocusing experiments, because you end up getting a lot of signal with your MRRV images. Because typically you're setting some amplitude and phase on all of the elements rather than shutting any of them off. So from an SNR standpoint, we don't feel like we would take a hit. In terms of the acquisition time, we still do believe it would be able to be done in a realistic time frame, because compared to other in situ methods that have tried to use MRRV refocusing, typically what they do is they attempt to estimate the amplitude and phase mismatch between all the elements within the living subject. So they do all of these different emissions while the subject is right there, compared to our method, which uses separate calibrations of the acoustic pressure fields within the free field. So we would need to do separate either ex vivo or simulated based acquisitions to get some estimate of what the free field acoustic pressure field looks like. And then we acquire the aberrated acquisitions after that and do magnitude least squares estimation to estimate the correcting amplitudes and phases. So at least in the paradigm that we published or it published in this abstract, it seems to work well with a fewer number of logical elements. And at least in simulations, we've seen a good amount of success with all the way up to 128 elements. So we're kind of keeping our fingers crossed, I guess, when we're if we wanted to translate this to the InSciTech system, which does have anywhere from a few hundred to 1,000 elements.
Yeah. There was a follow-up question for Sumit that in translation, would you have to repeat the MR-RP scan after each time you steer within the brain?
Yeah, that's a good question. So you would need to do that, because essentially what we're getting is feedback from the target in terms of what the actual what the aberrated acoustic pressure field looks like at the target location. We would probably need to get separate, provided that we know what the shift in the amplitude and phases is in the free field compared from the nominal free field location to the steered location. We would probably need to do separate calibrations for that. But since that's done in the free field anyway, there wouldn't be any kind of change in acquisition time. So we would in fact have to repeat the MRRV scan, but compared to some of the other previously published methods, we wouldn't need to acquire a significant number of acquisitions. So the answer is yes, but still we would be pretty hopeful that it would still require a reduced number of acquisitions.
Okay.
Okay, Nathan, there's a lot of interest in the chat in your work. So one of the questions, I guess, there's two questions here. So we'll start with the first paper, the accumulated thermal dose paper. So just commenting on the threshold value of 17 CEM, which, so as you commented, and I also noted, so compared to your rabbit paper, it actually, if you used the same coefficient, it would be quite a bit lower. It would be close to like 4 or 5
Yes.
CEM43. So other reports, so the comment in the chat cited Huang et al. And Jones et al. Both found 100 CEM43, and Seasons found about 40. So can you just comment on what factors might play into this much lower estimate?
Sure. For Seasons, he compared the dose to the lesion and T1 weighted images. And some other work out of Sunnybrook showed that appears a bit smaller than in T2 weighted images that I used. So that would move the edge of the lesion a bit inward. So that might explain why Seasons saw a higher one. With the other papers from Huang and Jones, I'm not sure why they saw a higher dose. But I would note that the gradient at the edge of the lesion that I measured was 100 minutes per millimeter. So even a very small difference in methodology could give you a pretty wide or big shift in the apparent dose. The values I just found agreed really well with the group from Zurich, who saw really good agreement with an 18-minute contour. And the maximum temperature that I saw was, I think, consistent with what the Virginia group saw. They saw a good correlation with 51 degrees, but it was under predicting the leisure, over predicting, whatever. It worked out that it was similar. So, but yeah, I think, we're trying to measure the threshold in this gradient, and the edge of the lesion moves. And the resolution is really low of the imaging. So it actually saw quite a range of thresholds, gave a pretty good agreement. But yeah, it basically just suggests that the value they use for guiding the treatment seemed to work pretty well, at least from my standpoint.
I was very impressed with how well your contours matched between your thermal dose and the actual lesion volume. So I think that's one of the best true shape matches that I've seen in the literature.
Yeah, I mean, it's when you steer the beam around, I mean, I'm assuming that the shape is retained when you steer the beam to different locations. And I had to do some, when I'm accumulating the dose in a plane that's different than the plane used for the thermometry, I had to make some assumptions about how the shape would be retained. I don't know if those are always right, but on average, it seemed to work really well.
I was wondering, in the one explanation or the one set of images you showed initially, you had kind of 3 worked well, and then I think was it the axial RL that was different? Did you find something over your 120 cases, something that consistently a certain one is off compared to the others, or was it more a random distribution?
There was no particular one, and I'm creating these templates that I use to scale based on previous sonications. And when the temperature rises low, I'm probably asking too much. I cut off, the values that I used where I would say, okay, I'm going to use this for a template at, I think, around 7 degrees temperature rise, and then tried to extrapolate based on that. So I think in some cases where I only had a temperature map where I had a low temperature rise, it didn't scale quite as well. So I think in that example, that was the case there. The only thing that I could say was that the thresholds were consistently, I think, lower in the axial images. And I'm not sure exactly why that is. But.
Okay, and then from your other paper showing that you can get the anatomical information from the phase data, so one of the questions in the chat is, wondering about when you say you're using all the phase maps to get filtered phase maps, do you mean all the phase maps during heating, or both before and during heating? And how are you determining weights for weighted averaging?
Sure. I use all of them. I don't know if I had to, but I just averaged everything together because I needed to improve the SNR from the individual phase maps. And I'm sorry I didn't include that. When I said that I weighted them, it was when I used the multi-echo thermometry sequence. I did a weighted average of the different echoes based on the expected SNR.
And then as a follow-up to that, could you run the thermometry sequence without fuss heating to plan or confirm your target location? And is there a benefit of doing that?
Yeah, there could be. Right now, I'm using it. We typically check it when we do the verify sonications. So that gives you a sort of you see minimal heating shining through. But you could certainly run it separately. You could increase the resolution too if you wanted to, or do improved averages. This is just using the same data that I had available. And what I'm doing now, I've been writing a tool where I sort of combine these two approaches, where I take all the sonications that we've delivered so far and try to predict what's going to happen on the next sonication, assuming we steered the focus or changed the duration or the peak temperature. So that trying to sort of evaluate that now to see how useful that is. It seems to help guide our neurosurgeon and give him more confidence when he wants to make a move, more laterally or more inferior, where you might start to run into issues with the capsule.
Yeah, that was actually my other question. If you have tried this kind of in a more prospective, or at least during the treatment fashion, and not just, I wasn't sure if that was purely kind of analyzing the data you had, but you're looking at that to improve the pre-treatment.
Yes, we do use it now. And and check it before we start escalating the power.
Okay.
Okay, and there's actually another question for Sumit. So just someone has noticed that the transducer used in the study was only about 10 centimeters and the images had a 5 centimeter by 5 centimeter field of view. So just wondering if there would be any issues when this scales up to some of the large brain systems that are used clinically.
Sure, and I hope I'm not misunderstanding anything with regards to the transducer hardware. I don't actually believe that would cause any sort of intrinsic limitations to how the technique would be implemented. From an image acquisition standpoint, I guess if you're running into issues with image wrap or something like that, that could be an issue. But ultimately, we don't actually need that much signal from a large number of voxels for the technique to work. So regardless of how large or small the field of view should be, really that shouldn't be too much of a limitation for this technique. Really, it's just going to come down to how well we can resolve differences in the contributions of the amplitude and phase from all the different elements, and provided that we are able to distinguish some of the fine differences between the signal that we get from MRRFE, really the SNR of the acquisition is really what it comes down to. So I don't think that would be a limitation.
Okay, great. And I see another one for Steve as well. So Steve, in terms of a quantitative comparison between your simulated CT and the real true CT data, have you compared differences in speed of sound and density, as well as thickness differences of cortical intravehicular bone that's measured on each?
So in this study, because we were using the Insightec system, which calculates its own speed of sound and density, and I did not make those comparisons between MRSIM CT and CT. In terms of trabecular and cortical bone, that's a good question, and I have not looked into that.
Well, I look forward to seeing some of that in some of your future work.
Mm-hmm.
Okay. So let's get back to Nathan again. So Nathan, when in the treatment workflow would you do the processing to recover the anatomy from the MR thermometry?
So like I said, we're currently doing it with the Verify sonications. And it's nice because it actually, you do see some of the heating come through, so it's really obvious where your spot is. One of the things I was curious if I could actually correct for this heating shine through by using the thermometry data, sort of subtracting it off. But I think, yeah, right now, but we do run it on each of the sonications. And right now, in reality, it's mostly to say, okay, to the neurosurgeon that we look safe if you want to go lateral or don't go more lateral. And is it, it's lined up a little bit more, anterior than normal. But eventually we'd hope to get this sort of in a real time. So right now it's sort of a manual tool.
Okay, great. And we only have a couple minutes left. So if we're going to go around the room in 30 seconds each, you could talk to us about when we might be able to see these techniques broadly adopted in a clinical setting. So I'll start with Steve. Oh, Steve, you're on mute.
Sorry about that. So I would say that we first have to get acquisition times down and then perform the experiments on at least in vivo experiments with large animal studies and then try it with human studies. And I don't have a good estimate for how long it would take, but these are the steps that would be needed to take in order to get there.
Okay, great. And Sumit?
Sure. So personally, I think MRRFE is a very promising technique. Both our group and other groups have shown that MRRFE is feasible in at least in non-human primate subjects. Really, the limitation here is just to see this implemented on the Insightec, the clinical systems, before we could translate it further. So I'd be interested to see how it works on those systems.
Okay, Nathan, you get the remaining time.
Okay. For the phase imaging, it would be very easy for Insightech or whatever company just to put a button to reprocess the images. It's a really simple image processing. For the dose and sort of scaling the dose to sort of predict what's going to happen next, I'm not sure if that's something that a company would want to do based for liability purposes to have, to say, I'm predicting this is what's going to happen. And so right now I'm keeping this as a research tool, but you never know. So eventually we'll get 3D thermometry, I hope, and this will sort of all be moved. But I think the main takeaway for that was that the values that they're using now seem to be okay.
Wonderful. And thank you to everyone for joining us and for your great answers and wonderful presentations.
Thank you.
Thank you.